So in my project work, I was actually hired in 2010, and I worked part-time for 3 years as an end-of-life project coordinator for the renal program. And the work I did was to implement the elements of the end-of-life framework. And I'll be talking about the 4 key elements of the BCPRA end-of-life framework as I move through this presentation. So I have a few did you knows on kidney patients. Mortality rates for patients with end-stage renal disease are worse than for most cancers, with an overall median survival of less than 6 years. And this does vary with age. So when I was on the floor doing teaching with staff, I often pulled up this bullet to raise some awareness. I found it was a powerful statement, it spoke to me with that survival of less than 6 years. The other thing I want to mention too is the average annual mortality rate of a dialysis patient is 20 to 25%. So annually, each year, we will lose 20 to 25 of our patients will die. And I do have some Island Health Renal Program statistics that I'll share with you a little later on. Another did you know, there's an increasing number of patients that are dying after withdrawing from dialysis. So 10 to 20, the research I found here was 10 to 15% of patients withdrew from dialysis in 1990. That almost doubled in 2004, representing the leading second cause of death after cardiovascular disease. And the other thing worth mentioning too is the vast majority of patients with chronic kidney disease die in acute care facilities without access to palliative care services. So this next slide here demonstrates the survival probabilities for end-stage renal disease patients. And the literature does report that the majority of patients on dialysis are over the age of 65. So if you look at this chart, over a 5-year period, just under 40% of these patients in the 60 to 64 age group will be alive in 5 years. I also want to mention a little bit about dialysis. It is, as you know, a life-sustaining treatment. Majority of these patients come, or just about all of them, come 3 times a week for 4-hour treatment. So the 4 hours that a patient is on dialysis is their actual treatment time. So if you tack on half an hour for hookup, half an hour for getting them, you know, all disconnected at the end, and then their travel time, it can make for a very long day for these patients. And for our senior population, knowing what we know, that most of our patients are over 65. So here are the numbers for the renal program. In 2011, across the island, there was 278 deaths in the renal program. 19% of our patients on dialysis, so that's including hemodialysis and peritoneal dialysis, died in 2011. 2012, slightly lower, we had 16% of our patients die. But if you average that out, that works to about 5 deaths a week, and that's pretty significant. I thought I'd tie in this slide as well, and what this is the trajectory of end-stage organ failure approaching end of life. So as you can see, over the time span of about 2 to 5 years, you'll see peaks and dips with these patients in their functioning. They'll go low and then they'll recover. Oh, they're back down again and they recover. And then towards their end in that terminal phase, they have many more dips, okay? And with the work I did, it was about ensuring that chronic kidney disease and end-stage renal disease patients and their families receive quality end-of-life care. So knowing what we know and what the trajectory looks like, I find it interesting when the death seems sudden. And I can attest to that as a dialysis nurse. If I put on my dialysis hat, we often see patients admitted in a crisis, oh, they recover, and I've certainly had many conversations over the years with, oh my gosh, I can't believe so-and-so died, right? They usually bounce back. So let me talk a little bit about some of the 4 elements of the BC Provincial Agency End-of-Life Framework. And these are the areas that I targeted over the 3 years that I did this project work. So it's again to ensure that these patients and their families receive high-quality end-of-life care guided by best practice standards. The 4 components, the first one is patient identification, so looking at prognostic strategies to help guide patients at high risk of mortality or in greatest need of supportive care. The second element was advanced care planning, so planning for a time when a client or a patient becomes incapable to make their own decisions. Pain and symptom management, and lastly, care of the dying and bereavement. So the first element is patient identification, so looking at prognostic strategies to help identify our patients at highest risk of mortality or in greatest need of supportive care. So one of the suggested prognostic markers is serum albumin. So looking at a serum albumin, if a red flag would be raised if somebody dropped below 25. Another one is comorbid conditions, so looking at, does the patient have, what comorbid conditions? Do they have diabetes, cardiovascular disease? Looking at the patient's age. I highlighted the surprise question because that was one of the prognostic markers that I really zeroed in on doing this project work, and I'll tell you a little bit about that on the next slide. So would you be surprised if this patient died in the next year? Another component is nutrition and functional status. The patient lost 5 to 10% of their body weight. How are they doing nutritional-wise? And lastly, sentinel events. Have they had recent or multiple emergency visits or hospital visits? But I really want to zero in, like I said, on that surprise question because that is one area that we were able to incorporate into practice. So the surprise question was incorporated into practice in the in-center hemodialysis units at the Jubilee and Nanaimo General on our outpatient population setting. And what the surprise question is asking the clinician, would you be surprised if this patient died in the next 12 months? And this has been a validated tool. If the physician answers no, I would not be surprised if this patient died in the next 12 months, the patient is 3.5 times more likely to have died in that year. Okay. So how we decided to incorporate it was at the time of medication reconciliation. And we do medication reconciliation about every 6 months on our patients. And it's also, not only do we do medication reconciliation, but it's a really good semi-annual review of the patients. So what we did is I made a little sticker. You can see it here on the screen. And I put it at the top of the patient list that we would be reviewing that day in rounds, and there would be a weekly rounds for MedRec and semi-annual review. And I put this little sticker at the top, hand it to the nephrologist at the beginning of rounds, and he or she would go down the list and write yes or no next to the patient's name. And what this was, it was a trigger for advanced care planning, or a flag that, does this client need more support? And again, it identified our patients that were at high risk. One of the challenges with this was workload. We have one social worker for a very large population. I think we have about 200 patients. And advanced care planning primarily falls to our social workers right now in Renal. They're the experts. Okay, so that was one of the challenges. In terms of integrated into practice, I must say that I didn't really have any barriers. The nephrologists were very receptive using surprise questions, and they saw the value. So it was a great little way to incorporate it into practice. And And it was great that it went so smoothly. I'd like to say this one was an easy win, and I'll talk about some of my other challenges as I move through. So the next element with the end-of-life framework is advanced care planning. So a little quick definition here. Advanced care planning is a capable adult's planning for how consent to health care will be given or refused after he or she loses capability. The process of learning, deciding, talking about, and documenting, or otherwise expressing what health care an adult wants or does not want. Conversations are the key. Okay, having these conversations are so, so important. A few did you knows around advanced care planning, and this is, I pulled this from an Ipsos Reid poll, from the Canadian Hospice Palliative Care Association. 86% of Canadians have not heard of advanced care planning, and 80% of Canadians agree that people should plan for the end of life when they're healthy, and yet 70% have not done so for themselves. So my message, if I put on my advanced care planning hat, which I have on 3 days a week here with Seniors Health, is really about how can we normalize advanced care planning and engage in these conversations. I wanted to do just a really quick review on some of the advanced care planning language, because I find that this is where there's confusion with the language. I decided to pop advanced care planning in this umbrella because I really do see advanced care planning as an umbrella term about planning for your future health care wishes. And then underneath it, these are components of advanced care planning. So your advanced care planning may consist of a representation agreement. Okay, legally appointed somebody to be your healthcare representative. And one of the major changes in the law in BC 2 years ago is you no longer need a lawyer to do a representation agreement. An advanced care plan may consist of an advance directive, which is now a legally binding document that gives or refuses consent to specific health care treatments. It may consist of an expression of wishes. And I tossed in the term living will here because it's a term that most people are very familiar with. However, it is a U.S. term, and it has never been adopted into our Canadian legislation. When I'm working in the seniors outpatient clinic or doing advanced care planning, I often will ask, have you done any advanced care planning? For example, a living will. And then I'll go into a little bit more depth about, it's an expression of your health care wishes. It's also worth mentioning, too, that a power of attorney in BC is for financial and legal decisions only. Okay? What is unfortunate with advanced care planning, each province is speaking a different language, and each province has different laws. I tucked in at the bottom of the screen here the My Voice, expressing my wishes for future health care, and this is the government guide for advanced care planning, and it contains all the documents you may wish to complete, or you may or may not need to do your own advanced care plan, and I tied in the link. And I thought this was a really good opportunity to just touch on some of the changes around advanced care planning that took place two years ago. The temporary substitute decision maker list has been broadened. As I just said, there's no longer a need for a lawyer or notary to do a representation agreement. Advanced directives have gained legal status. They are now a legally binding document. And all healthcare providers, as well as paramedics, are legally required to honor an advanced directive. Okay, so that's a big change for our paramedics. They used to be bound to follow a signed doctor's order. Now they can follow something that is not signed by a physician. One of the biggest challenges with the advanced care planning component of the project work was the education around this, and impressing upon healthcare providers that healthcare consent advanced care planning is all our responsibility, and that was a big challenge, the education piece and getting everybody educated on advanced care planning and consent to healthcare. So when we look at advanced care planning, ideally, who should we have the conversation with? And it's really, ideally, we should be having these conversations with capable, healthy adults, and again, normalizing it. It's more imperative with adults with chronic disease before they become acutely ill. And I'm pleased to say that advanced care planning is introduced in our kidney care clinic here at Island Health. And it is absolutely, I think it's absolutely essential with adults that we anticipate to be in their last 12 months. And again, that's where we tied in the surprise question. Some of the barriers and roadblocks with advanced care planning: discomfort with the topic, lack of understanding, belief that it's not my job. Okay, one of the statements that one of the nurses said in my work around this was, I deal with the physical, the social work deals with the feelings. Okay, so it was and that indicates to me the need for a little bit more education around this area. Not enough time, not the right time. The environment, that's a huge component in a dialysis unit because patients are often only a couple feet apart. The culture in a dialysis unit, the patients are here so we can save their lives and keep them alive. And the last bullet I put here is, we don't want to suggest that someone is giving up. Okay, we want this to be a happy environment. Okay, so these are some of the things that I encountered in my project work in Renal, and that I continually encounter in my advanced care planning work. I better move forward because I could talk all day about advanced care planning. I threw in this slide here too. Does ACP engagement take away hope? When ACP is timely and appropriate, it can positively enhance rather diminish patients' hope. I always say knowledge is power. The more knowledge you have, the better able you are to make informed treatment decisions. So some of the things that we did in Renal to incorporate ACP into practice was the Green Sleeve Initiative. And we followed the leads, Fraser Health. They've done a lot of work with the Green Sleeves, and they are one of the leads with advanced care planning. So I did a lot of collaborating with Carrie Hoffman over at Fraser Health to try and get these Green Sleeves implemented in our Renal program here. So what the Green Sleeve is, it's a green plastic folder where we put any advanced care planning documents, and it goes on the front of the patient's chart. And the code status sits right at the front. And these Green Sleeves, they're see-through, so at a glance, if you pick up a chart, you open it up, you will see the code status right on the front. And then tucked in behind are any advanced care planning documents, such as a representation agreement, advanced directives, expression of wishes. So it's really a storage document for these advanced care planning documents. We also incorporated a tracking tool. And what this, you can see a little example here on the screen. What the tracking tool is a place where you can chart conversations around advanced care planning. So goals of care, did anybody give the My Voice book? Did they introduce advanced care planning? Did the patient talk about what's important to them, or any wishes? And what this tracking tool is, it's just a place where you can write a brief little note, and other healthcare providers know where to find these conversations in the chart. And we implemented these Green Sleeves throughout the Renal program in all our outpatient areas. One of the other things I wanted to articulate and have the opportunity to articulate is, think about the language that you're using when it comes to advanced care planning. We tend to say, who is your emergency contact or next of kin? And that might not be the person authorized to provide consent if the patient becomes incapable. I'm going to move forward to my next slide. This is an example out of our Island Health electronic database of emergency contact. Okay, so I'm going to pretend I'm taking, let's say I have this client who has a severe infection, and the day I'm taking care of her, she's delirious and she can't provide consent for treatment. One of the things that I may do is go into our database to see who's her contact. And if I go to her emergency contact, that is not actually telling me who is providing consent for treatment. I don't know if she's done a healthcare representative. I don't know what advanced care planning documents she has. There's an article that I recently came across, and it was on some research that was done with people in an outpatient dialysis clinic in the U.S., and 3 out of the 94 people that were surveyed had appointed a legal substitute decision maker. And 63% of the time, they chose a substitute decision maker that was actually the same as the emergency contact, which is wonderful. But what I want to highlight is 1 out of 3 times the emergency contact was not the appropriate person, okay? So if the lady, pretend I have Anne in front of me who is in that delirious state, if she does not have a representation agreement, this is the temporary substitute decision maker list that you would go through, the healthcare provider needs to go through to figure out who provides consent for treatment. Okay, so Anne may have put in her emergency contact her close friend, when actually it would be her spouse or adult children, if she had any, who would be providing consent. So what I'm trying to say, I don't know if I'm making myself clear or not, it's hard doing a teleconference because I can't read the audience, is just be mindful of the language you're using, okay? Instead of asking somebody if they have an emergency contact, perhaps ask them if they've done any advanced care planning. Have they legally appointed a healthcare representative? And if they haven't, then it is actually the healthcare provider that goes through the TSDM list. So think about your practices. Ask about advanced care planning. I encourage you to please document the conversations, and think about where are advanced care planning documents currently filed in your area. On the screen here, I won't open it up because I need to keep moving. Myself and one of our renal social workers developed 2 information sheets that I'm happy to share with you to help raise awareness and staff engagement. So I have embedded these in to share with you. I'm going to move next on to pain and symptom management. Symptom burden in renal patients is known to be very extensive, severe, and really significantly impacts their quality of life. These are some of fatigue, pain, decreased well-being, poor appetite, anxiety, and depression are the most severe symptoms reported in literature. A few did you knows, patients with chronic kidney disease, particularly those with end-stage renal disease, are amongst the most symptomatic of any chronic disease group. And the patients often believe that their symptoms are untreatable or unavoidable, or an unavoidable consequence of their disease, and it's often underreported because of that. So what we embedded into practice was the Edmonton Symptom Assessment Scale. And what that is I have a picture of it here. It's a measurement tool that was initially developed for cancer patients and was modified and validated by a nephrologist, Dr. Davidson. And it measures 11 physical and emotional symptoms. And each symptom is scored on a visual analog scale from 0 to 10. So we embedded this into practice across our program, in our kidney care clinics, peritoneal dialysis unit, home dialysis unit. And what is wonderful is the patient rates their symptoms. And this is an example of our renal database where the ESAS can be tracked and trended over time. So we can input the data, and if I'm working in the dialysis unit and I don't know my patient today and he's having some symptoms, I can go into the database and pull up previous ESASs to see, is this something new, and be able to track and trend their symptoms over time. Some of the challenges with the ESAS was we were identifying problems with our patients, but we didn't have a Cardex in place. So we were identifying problems, and then we didn't know where to put them, and we didn't have a plan of care in place. So what's really encouraging, that as a result of implementing the ESAS, a care plan, an interdisciplinary care plan, was developed and is now currently just being rolled out, where we can chart patient goals of care and high scores on the ESAS, and we know what the plan is moving forward. Okay, the other gap that was identified around the ESAS is this tool was implemented again at the time of medication reconciliation, and not all of the team sat at the table. So we have our nephrologist, our pharmacist, and our dietitian, but nursing and social worker weren't at the table for that semi-annual review. So that's one of the other challenges and gaps you know, to try and incorporate interprofessional collaboration. I mean, ideally, it would be nice to have the patient at the table as well to have the discussion. So there were a few gaps that were identified as a result, but some great steps were made moving forward, and I'm very excited about the care plan being implemented. The other practice change was the implementation of a pain assessment form, and I have an example of it here. So it's a very comprehensive pain assessment form, covers quality, impact on function, relieving factors, history, side effects. And how we incorporated this pain assessment was on any new pain 7 or greater. Okay, and there was a lot of teaching and review that had to be due around that took place around pain, right? You need to believe the patient's report of pain. What was nice with this pain assessment form is it's a systematic approach, and the other piece too is tightening up the gap between our nephrologist and our GP and the communication between them, and having one prescriber. The other piece and the other challenge is our documentation. And again, I think what I identified was there was a lack of documentation around pain in the charts, and I think having this care plan being rolled out, that will really help tighten up that gap and improve the communication and documentation within the team. These are a couple examples of the patient information sheets that were also developed by myself and the Renal End of Life Committee for our patients, and we've put these in the waiting room. And I've also tucked in these BCPRA resources. So there's some great information on the BCPRA website, and I have it in my resources at the end on restless legs, pruritus, insomnia, and the chronic pain. This one here that you see on pain, what we do in practice in the dialysis unit is if the GP is handling the patient's pain, we always be sure to fax this over to them as well to help to raise awareness if they're not aware of these guidelines, and to help with prescribing. So my last element of the 4 elements of the End of Life Initiative was bereavement. So acknowledging the emotional aftermath of a patient's death by providing grief and bereavement resources to family, friends, and staff. Some areas, some dialysis units were already doing some work around bereavement, but we didn't have a standardized approach, okay? So when I started to do some work around the bereavement, I started in one of our dialysis units in Nanaimo, and I sent out a staff survey and a patient survey to get their thoughts. And here's some of the responses. So 79% felt that it was important, this is from the patients, for the staff to acknowledge the death of a patient. 76% of the people surveyed wanted to know when a patient dies. And the culture of a dialysis unit, you know, often you're sitting next to the patients are sitting next to that same person over many years and establish relationships. One of the challenges, too, is we had to get around the confidentiality piece, because if the nurse knew that a patient had died and we didn't have consent from the family to share this information, then we weren't in a position to be able to share it. So by developing a renal program bereavement protocol, embedded in it right at the top was consent received from patient's family to share information on the death, okay? And that helped with staff, too, in terms of being able to share the death and not being in that awkward position of, well, I know I shouldn't be sharing, but, you know, they know them so well. And as a result of the survey, this unit wanted to have a photo frame in the waiting room with patient information and an obituary. So the outcome is a renal program standardized bereavement protocol was created, and it just provided a little bit of standardization across the program. And what we decided to do too, based on feedback from staff and patients in certain units, how they acknowledge the death could be different from unit to unit. So again, for this in this unit, they decided to put a little photo frame and obituary in the waiting room to share the information. So outcomes of a palliative approach. It's been demonstrated that when a palliative approach is part of care for those with chronic illness, there are improved outcomes for the person, family, and healthcare system. Okay, so a good death in the most appropriate location. And this is all according to research. Better pain and symptom management, better long-term outcomes for bereaved relatives, improved experience of care, better quality of care, lower health care costs. And when I'm out in the public talking about advanced care planning, I always say it's about having your wishes known and followed. Okay. So this is my pulling it all together slide. Care of the end-stage renal disease patients on dialysis requires expertise not only in the medical maintenance of patients on dialysis, but also in the palliative care that focuses on other symptoms, advanced care planning, and attention to ethical, psychosocial, and spiritual issues related to starting, continuing, withholding, and stopping dialysis. I've included a slide with all of my references and a few resources. So the BC Seniors website is a resource I often use for advanced care planning. It's one of my one-stop shopping places. The BC PRA website I've tucked in there, and you can find lots of information around the end-of-life initiative, and of course the iPANEL website. So I want to thank you for this opportunity. I remember chatting, Deanna and I chatting in my early days when I started this work with the renal program, and it's about a culture shift that really needs to take place, and that takes time. It can take a couple years to have a little bit of a culture shift, and I'm really happy to say towards the end of my work with this project, there was a shift, and that was really nice to see. In dialysis, we can become very technology focused, very machine focused, and by incorporating some of these elements into day-to-day practice, there was a subtle shift in the care that was provided. So I do walk away. I walk away from the work I did with feeling good and knowing that changes were made and embedded into practice, and I'm happy I could share that with you today.